Hello, everyone. Welcome to the first ISARIC COVID Evidence Forum. My name is Bharath Kumar. I'm an intensive care physician working at Apollo Hospitals in Chennai. I'm also the national lead for the Indian Registry of Intensive Care, and I'm an honorary senior fellow at the George Institute for Global Health, New Delhi, India. It's my great privilege to be moderating the session with a very distinguished panel of speakers. I'm just moving my slides. Just give me 1 second. Yeah, my disclosures as relevant to this forum is that I'm an international trial steering committee member for the COVID steroid 2 trial, which will be discussed today. And that's my email and Twitter contact information. The partners for this event are the International Severe Acute Respiratory Infection and Emerging Infection Consortium, the George Institute for Global Health India, the Indian Registry of Intensive Care, and the Chennai chapter of the Indian Society of Critical Care Medicine. This is the social media information of all our partners, and the hashtag for this event is #ISARIC, and ISARIC is also on Facebook at ISARIC Global. If you're tweeting about this event or if you're sharing, please use the hashtag and please do tag all of the partners. Thank you. So before we get started off, I just have a couple of slides and then I'll be handing over to the first speaker. So why this forum? All of the partners involved in this event are committed to the dissemination of published evidence and to facilitate its translation to bedside practice. And that's the key objective of this forum. We will also be exploring knowledge gaps and residual uncertainties around the use of steroids in COVID-19 today. We will try and discuss the way forward in advancing the science on steroids in COVID-19. And all of this, of course, we try to do through stakeholder engagement and events such as the one that we're having today. So why steroids in COVID-19? I think you're all very familiar with this image, perhaps one of the most downloaded images of 2020. But conceptually, COVID-19 is thought to have a stage 1, which is the early infection phase, which is characterized by viral response, and then the stage 2, which is the pulmonary phase, and then there's a stage 3, which is the hyperinflammation phase. In stage 1, patients typically tend to have mild constitutional symptoms, and then when they progress into the pulmonary and hyperinflammatory phases, they go into organ failure, requiring oxygen, and so on. By attenuating that inflammatory response, steroids might play a beneficial role in COVID-19, and we now know that to be the case. So today's forum is essentially going to be talking about how the evidence has evolved and where the knowledge gaps are. The agenda, we'll first have the presentation of the results of the recovery trial specific to the DEXA arm by Professor Peter Horby. We'll then have the meta-analysis of COVID-19 steroid trials by Professor Jonathan Sterne. Dr. Ajay Padmanaban will be presenting on steroids and non-COVID ARDS and what are the lessons for COVID-19. And then Professor Sheila Myatra will be presenting the International Multi-Center COVID Steroid 2 trial. We are hoping to have a 10 to 15 minute, very good interactive session at the end of question and answers. I would request you all to post your questions in the Q&A box. If you have a dedicated Q&A box instead of the chat box. And if your question is to a specific speaker, please do indicate that along with your question. So that's the standing instruction for the session. It's now my great privilege to introduce Professor Peter Horby, who is the first speaker. Dr. Horby is a professor of emerging infectious diseases at the University of Oxford. He has led clinical and epidemiological research on a wide range of emerging and epidemic infections for more than 15 years, which includes SARS, avian influenza, Ebola, plague, and of course, COVID-19. He is also well known to all of us as the chief investigator of the randomized evaluation of COVID-19 recovery trial, which is the largest trial evaluating COVID-19 interventions. And if I'm right, has randomized more than 18,000 patients to date. Professor Horby, welcome to the session. It's my great honor to have you here and introduce you. Over to you, sir.
That's fantastic. Thank you very much, Bharath. It's a great pleasure to be here. I'm always excited to talk about our progress with steroids and really to find out, as you said, what the next steps are. It's important that we evaluate the evidence we've got and think about what are the next pieces of work we need to do to really make sure that the evidence is transferable to different settings. So I'm going to talk about the recovery trial, where we looked at dexamethasone. Recovery trial is a UK-based trial, and we published the results of the preliminary report in the New England Journal of Medicine. The final report will be out shortly. We're just revising it now. It really does not change any of the results. There's just a bit more data on some other outcomes like renal outcomes, etc. We chose dexamethasone to go into the trial because there has been data in the past on respiratory viral infections and the use of steroids, and it was a very mixed picture. Some reports of higher dose steroids suggesting harm in terms of prolonged viral replication, complications, poor diabetes control, very high doses avascular necrosis of the hip, but other studies, particularly in ARDS, suggesting that there may be a benefit. And this was really a non-resolved question. So this was the original design of the recovery trial, where we had a primary randomization between 4 repurposed drugs: lopinavir, ritonavir, the HIV drug, dexamethasone, 6 milligrams once a day for up to 10 days. So if the patient is discharged, they stop treatment, hydroxychloroquine and azithromycin. And we chose the repurposed drugs so that we could get these drugs into the trial quickly. And then later we introduced a second randomization to tocilizumab versus no additional treatment in patients who deteriorated and became hypoxic with a raised CRP. So the reason we chose dexamethasone is because it's got a strong glucocorticoid potency, which is what we wanted for the anti-inflammatory effect, but no mineralocorticoid potency. So would not be a problem in those with heart failure, etc., which is an issue in COVID-19 because it's a very elderly population. It also has quite a long half-life, so it was a good choice in that sense. Now, people will argue whether 6 milligrams once a day is a low dose or a high dose, and I think it depends who you are. If you're a primary care practitioner, it might be perceived as a high dose, but for intensive care physicians, it's definitely seen as a low dose. We kept the trial simple, very simple randomization form, 1 page with no follow-up other than at 28 days, with the primary outcome being 28-day mortality. And we used data linkage to get additional data. The primary data is mortality at 28 days, but we're also assessing at 6 months. Secondary outcomes were time until discharge from hospital. And amongst those patients who did not receive invasive mechanical ventilation at randomization, whether they subsequently progressed to invasive mechanical ventilation or death. And we had some other supplementary questions as well. So the results, we recruited across the UK in 176 hospitals, and we had, there would be 2 ways to stop randomization. One is when we reach 2,000 patients on treatment versus controls, on the basis that with an estimated case fatality rate of 20%, 2,000 patients versus 2,000 patients would give us 90% power at a p-value of 0.01 to detect a relative reduction in mortality of 20%. So that's a modest reduction, but also an important one. And so we stopped the dexamethasone trial when we reached that threshold. The other way to stop the trial is when the Data Safety Monitoring Board tells us that we've reached the threshold of either efficacy or safety. So you'll see here that we called the dexamethasone arm when we had 2,104 patients on treatment and 4,000 patients for the control group. We did a 2-to-1 randomization at this stage because we had multiple treatment arms in the first part of the trial. So we needed an additional group of controls to make sure we had adequate power. You can see at the start of this flow diagram that nearly 2,000 patients were excluded either because dexamethasone was not available at the time on the ward or because patients were considered unsuitable for randomization. And then 9,355 underwent randomization. And so the control group is only those patients who were eligible to be randomized to dexamethasone. So it's important to remember that if you were deemed as unsuitable to get dexamethasone, then you're not included in the control arm. You're only in the control arm if you could have been randomized to dexamethasone. And as you see here, we did an intention to treat analysis. And so here is the characteristics of the patients. Now, through randomization, we expect the groups to be balanced. There was a slight imbalance in age between the groups. So you can see in the dexamethasone group, the mean age was 66.9 years, and it was lower in the usual care group, 65.8. That was entirely a chance effect, but given the importance of age on mortality, it's the strongest predictor of mortality, we did correct for that age imbalance in the analysis, but we also did a sensitivity analysis where we did not control for age, and we got exactly the same result. And you'll see that if you look across the last three columns of no oxygen, oxygen, invasive mechanical ventilation at randomization, you can see there is an age differential where the patients who were given invasive mechanical ventilation tended to be younger than the other patients. And this really reflects standard practice that very elderly frail patients may not be put on a ventilator. So patients who are in their 80s, 90s, who are very frail, may not be ventilated. And otherwise, you'll see down there that the median number of days since symptom onset to randomization was 8 days. So patients are coming into hospital after about a week of illness when they start to deteriorate. And they'd been in hospital on average of 2 days before they were randomized. There was a fair distribution of comorbidities. So over half the patients had any comorbidity. And again, comorbidities were higher in the no oxygen group and lower in the invasive mechanical ventilation group, again, reflecting practices to not send very frail patients to ICU. And you'll see here that we did not require a positive SARS-CoV test to be in the trial because there were delays in getting the tests at the start of the study. But about 90% of patients were SARS-CoV positive. And again, we did a sensitivity analysis looking at the results with only those who were positive and all patients. This shows you what patients actually received. And you'll see that amongst the dexamethasone allocated patients, about 95% received it. And in those allocated to usual care, about 8% of patients did get dexamethasone. What this means is that there is some what you might call contamination of the standard care arm with patients who receive dexamethasone. And the effect of this will be to actually reduce the real impact, so that the apparent impact looks a bit lower, because actually not all of the controls were not on dexamethasone. So any estimates we have from this are probably an underestimate of the treatment effect of dexamethasone. Very few patients received any other COVID-related interventions other than azithromycin, which is also in recovery as an anti-inflammatory antibiotic, but it's well balanced across the trial arm, so should not have any impact on the results. So here's the primary result. When we unblinded the data, this is what we saw initially, and this is based on 99.9% of patients having completed follow-up. That the mortality at 28 days was lower in patients who received dexamethasone. So a death rate ratio of 0.83 that was statistically significant. But when we looked at a pre-specified analysis of outcomes stratified by severity at randomization, it was clear that there was significant heterogeneity. You'll see here that in those on invasive mechanical ventilation, there was a very big effect in favor of dexamethasone, a death rate ratio of 0.64, so around about 40% reduction in the rate ratio. Those on oxygen, a benefit with a rate ratio of 0.82, but in those who were not receiving oxygen, there was not a benefit. And actually, the rate ratio was in favor of usual care being better, although not statistically significant, but certainly no evidence of benefit in that group. So although overall there's a benefit, there's substantial heterogeneity, and the chi-squared test was significant, meaning that really the right thing to do is not to aggregate this data, but to present it separately by these strata. And that's what you see here. So on the left, the usual care versus dexamethasone in invasive mechanical ventilation, about 1,000 patients, clearly showed a very big benefit from dexamethasone. 28-day mortality was over 40% in standard of care and under 30% in those given dexamethasone. And in the oxygen-only group in the middle there, you can see dexamethasone is beneficial. 23% mortality versus 26% mortality. But in patients who were not requiring oxygen, there really was no benefit. In fact, dexamethasone was on the wrong side of usual care, with a higher mortality in patients who didn't require oxygen. So the upshot of that really is that the recommendation from our trial anyway was that a very strong recommendation to give dexamethasone in patients who were mechanically ventilated or requiring oxygen, but also a recommendation to not give dexamethasone to patients who are not requiring respiratory support. So as I said, the results were similar in post-hoc analysis that looked at only the positives and the negatives, and also when we did not adjust for the age difference. And we saw consistency across the secondary outcomes. So the secondary outcomes here, the percentage discharged from hospital within 28 days was 67% on dexamethasone and 63% on usual care, so a higher proportion being discharged, statistically significant. And then the other secondary outcome of a composite measure of progression to invasive mechanical ventilation or death in those who were not mechanically ventilated at randomization was lower in the dexamethasone group, so less likely to progress to either mechanical ventilation or death if you were given dexamethasone. If we look in subgroups, you see a pretty consistent effect. You see the effect across the age groups at the top there. You see the effect in men and women. You see the effect most clearly in patients who are later in their disease, greater than 7 days since symptom onset, and you don't see it in those who are within 7 days. And this really reflects the same pathology, I guess, you're seeing with the oxygen, no oxygen group, that if you're early in disease and don't have inflammatory lung disease, you won't benefit from dexamethasone. I'll ignore that slide. And then we looked in some post hoc analysis that was recommended or requested by the European Medicine Agency. You can see the pattern is very consistent. By age, there's no difference by age in the no oxygen group, no benefit. There is a benefit in the oxygen group, whatever age you are, and in the mechanical ventilation group, whatever age you are. And same if you've got heart disease or no heart disease, no benefit if no oxygen, benefit if oxygen, mechanical ventilation. Same with diabetes. If you've got diabetes or not, giving it doesn't help if you don't need oxygen, and it does help if you do need oxygen. And same again for lung disease and kidney disease. So a very consistent picture that steroids do benefit patients of all ages, comorbidities, etc., if they require oxygen or mechanical ventilation, but doesn't benefit if you don't have inflammatory lung disease. So the summary really is that the results from the recovery trial suggested that overall, if you treated 12 patients who required oxygen or mechanical ventilation, you would save a life. And in those on mechanical ventilation, you'd only need to treat 8 patients to save a life. And given that the cost of dexamethasone is so low, this makes it a very cost-effective intervention. Thank you very much.
Thank you, Professor Horby. We'll take questions at the end. Our next speaker is Professor Jonathan Sterne. Dr. Sterne is a professor of medical statistics and epidemiology at the University of Bristol. He is an international research leader in medical statistics and epidemiology and has led the development of tools to assess the risk of bias in both randomized and non-randomized studies. Professor Sterne also leads the ART cohort collaboration of European and North American HIV cohort studies, which has made substantial contributions to understanding the prognosis and treatment of people who are unfortunately living with HIV. Professor Sterne, welcome to the session. Over to you.
Thank you very much for the opportunity to present these results, which are on behalf of a large worldwide collaboration, and I was privileged to be a part of it. So I'm presenting this prospective meta-analysis of COVID-19 corticosteroid trials, which was published in JAMA on the 2nd of September this year. Systematic reviews and meta-analyses should underpin evidence in medicine and provide the best evidence, but there are problems with many or most meta-analyses in that they come late after the publication process is complete. They can be compromised by missing information and affected by reporting biases. And our prospective approach sought to overcome these problems. So in a standard meta-analysis, we wait for a trial is conducted and then eventually is published. Some trials may have negative results and so on, and they're done over time. And then eventually we can conduct a meta-analysis. And it's often the case that not all the trials are published, and the lack of publication may be related to the direction of the results, leading to a risk of reporting bias. So in our prospective collaborative approach, trials were prospectively identified using online registries. They were approached for participation. So trials were identified before results, thus preventing results affecting their participation. And then the protocol was developed in collaboration with the trialists, and that was particularly important in deciding the subgroup analyses we were going to do, and all the trials were included in the meta-analysis, which we therefore hope is unbiased or at least less biased. And this prospective approach, which is published in the references shown here, has been suggested and was suggested before this year as particularly appropriate in situations of health emergency. Of course, we worked rapidly. The WHO Clinical Characterization and Management Research Working Group began work on a prospective meta-analysis in April. We were drafting a protocol during May and June. As Peter has said, Recovery released its dexamethasone results on the 16th of June, following which the WHO chief scientist invited trial investigators to participate. We discussed with JAMA the publication of 3 trials in the prospective meta-analysis simultaneously, had done the first meta-analyses by the 16th and 17th of July, submitted the paper on the 27th of July, and it was finally accepted on the 21st of August and published on the 2nd of September. So in the searches for eligible trials, 16 trials were identified, 7 were excluded, 9 trial investigators were contacted for participation, and 2 did not participate. 1 never responded, and the other declined participation because it alone decided to continue randomization between dexamethasone and between steroids and no steroids after publication of the recovery results. So we included 7 trials. Now these all recruited, we focused on critically ill patients, and the other trials all specifically were restricted to critically ill patients. And so for recovery, we included only patients who were invasively mechanically ventilated at randomization, although we'll show comparative results with patients who were receiving oxygen but not invasively mechanically ventilated. A further trial was identified only on publication, and we included a meta-analysis with its results in supplementary material for our paper. So I'm going to now show you the results of the meta-analysis, and just to emphasize, these are based on odds ratios, so not risk ratios. The overall odds ratio from the fixed effect analysis, as you can see here, was 0.66. And that corresponds to saying that for an assumed mortality risk of 40% with usual care or placebo, the corresponding mortality risk with corticosteroids is 31%, a reduction, overall reduction of 9 per 100, so a little bit less than the 12 per 100 that Peter presented in his presentation a few moments ago. 3 of the trials, including recovery, randomized their patients to dexamethasone, and the majority of these were recruited to recovery, and so the odds ratio is similar to that in recovery. The odds ratio in recovery is 0.59, and the odds ratio from the meta-analysis is 0.64. 3 trials randomized their patients to hydrocortisone or standard care. They're shown here. And the odds ratio for these trials was 0.69, similar to the odds ratio for dexamethasone, 0.64, although as you can see, fewer patients were randomized in these trials, and so the effect was less precisely estimated. And finally, one trial, the steroid ISARIC trial, which was conducted in China, randomized its patients to methylprednisolone. There were only 47 patients included in this trial, so the effect was imprecisely estimated, and that's so there's rather limited data on the effect of methylprednisolone. You can see that we divided the trials in advance according to whether we considered that they administered high or low doses of corticosteroids. We didn't find evidence that the effect of high doses was more beneficial than that of low doses. A major advantage of this prospective approach and of assembling data in a standard form from all the trials is that we can do standardized analyses comparing subgroups across the trials. That's usually difficult in standard meta-analyses. And here are the results for comparing patients who were not and were invasively mechanically ventilated at the time that they were randomized. So there only 4 trials included patients who were not invasively mechanically ventilated. And as you can see, there are only 144 such patients and 42 deaths. Nonetheless, the beneficial effect of corticosteroids appeared greater in critically ill patients who were not than were invasively mechanically ventilated. For comparison here, we've shown the effect already explained to you by Peter in patients who received oxygen but without invasive mechanical ventilation in the recovery trial. We were able to divide the patients for 6 of the trials, but not recovery. We were able to divide the patients according to whether they were taking vasoactive medication to support their blood pressure at the time that they were randomized. And you can see that the beneficial effect of corticosteroids appeared greater in patients who were not than were taking vasoactive medication. And then finally, there was little or no evidence that the effect of corticosteroids varied according to age of randomization, below or above the median of 60, according to sex, or according to whether patients had been symptomatic for less than or equal to or more than 7 days. We did look at serious adverse events as recorded in each trial. Their definitions varied markedly between the trials, and we didn't have results for serious adverse events available from recovery. What you can say, taking all these results together, is that there was little or no evidence of any increase in serious adverse events in patients randomized to corticosteroids. But because of the diversity of the definitions of serious adverse events, we did not conduct a meta-analysis. So to summarize, this was a successful collaboration convened by the World Health Organization between trial investigators, methodologists, guideline developers. So the WHO guidelines were updated and published simultaneously with the prospective meta-analysis, and medical journals. And we worked very successfully with JAMA to publish the prospective meta-analysis and individual trials at the same time. And we were able to work rapidly to conduct this prospective meta-analysis of 7 randomized trials, including 1,703 critically ill patients with COVID-19 recruited from 5 continents. Administration of corticosteroids reduced all-cause mortality at 28 days after randomization. There was no suggestion of an increased risk of serious adverse events. The estimated effect of hydrocortisone was consistent with that of dexamethasone. There was no evidence that high-dose corticosteroids were more beneficial than low-dose corticosteroids. Corticosteroids reduced mortality among critically ill patients who were and were not receiving invasive mechanical ventilation at randomization. The reduction in mortality appeared greater in patients who were not receiving vasoactive medication at randomization compared with those who were receiving such medication, but the results were not definitive in this regard. Thank you very much for your attention.
Thank you so much, Professor Sterne. We'll take questions at the end. I request the audience to please post the questions in the Q&A box and not in the chat box. And please, if you have a specific speaker that is directed at, please mention their name as well. Thank you. Our next speaker is Dr. Ajay Padmanaban. Dr. Ajay Padmanaban is an intensive care physician working at Apollo Hospitals in Chennai. He trained originally in anesthesiology from the Postgraduate Institute of Medical Education and Research, Chandigarh, and then went on to complete training in intensive care at Apollo Hospitals. He has completed his Indian diploma as well as Indian fellowship in critical care medicine. At Apollo, he leads the post-ICU recovery clinic and the post-ICU recovery program. He is also additionally the site investigator for the COVID steroid 2 trial. Dr. Ajay will be presenting about the use of steroids in non-COVID ARDS and how it's informed its use in COVID. Dr. Padmanaban, thank you for joining. Over to you.
Thank you, Dr. Bharath. Multiple trials have actually now proven the efficacy of corticosteroids in severe COVID infection. So now looking back at this evidence, one begins to wonder if these results are on expected lines or completely unexpected. So to understand this, we need to look at a similar clinical entity, which is ARDS, which has an extensive body of evidence evaluating corticosteroids in ARDS. And we need to understand that although there are phenotypical variations in severe COVID, is essentially ARDS. It fits the Berlin criteria definition, and severe COVID is managed as ARDS. So during this presentation, we will review the evidence, existing evidence for steroid use in ARDS. And through this evidence, we can see if there are any lessons that need to be learned in the similar management of COVID with corticosteroids. Before starting to look at this evidence, we need to understand that we can't look at ARDS as a single monolith. We need to look at it through prism of three different clinical syndromes, which are separate as well as overlapping. ARDS by itself, which has its severities of mild, moderate, severe. There is a category of patients with septic shock who are intubated, mechanically ventilated, who are hypoxic, and the category of patients with severe pneumonia. I believe the three syndromes overlap, and it is the overlapped areas which have similar pathophysiology and are likely to be responsive to COVID, likely to be responsive to corticosteroids. So the lesson that we need to learn here is, for example, the category here, we look at severe pneumonia. The milder forms may probably fall away from the overlapped area and may not be probably responsive to corticosteroids. So it's overlapping as well as separate conditions. At the beginning itself, I would like to exclude conditions such as acute eosinophilic pneumonia, organizing pneumonia, vasculitis, which are ARDS mimics in that they are clinically similar to ARDS. They would fit the Berlin definition, but pathophysiologically and histopathologically are different conditions and tend to be extremely steroid responsive. So steroids were always going to be an effective drug, a drug of interest in treating ARDS, considering that it has anti-inflammatory, anti-fibrotic properties. So looking at the evolution of evidence, I would like to, there were many studies prior to in the early 1990s and 80s too, but I would like to start off from 1998 onwards. There were a series of RCTs in the late 90s and early 2000s, which evaluated the efficacy of corticosteroids in COVID. The results were of low quality and did not bring any practice change. Then came a meta-analysis which analyzed the RCTs which came in the previous period, and they did raise some amount of positive vibes for the use of corticosteroids in ARDS. Then came a recommendation from the SCCM and ESICM based on this meta-analysis. And again, although there was a recommendation for steroids, it was still not very popular. I believe that this trial, the DEXA ARDS trial by Jesus Villar, was significant in that it is a stronger study and generates much more high quality evidence in favor of corticosteroid use in ARDS, and then we landed up in the pandemic this year. So just to summarize the findings of the initial RCTs, we see a particular trend. Basically, most of them are small. We had familiar names. We saw medullae featuring quite often. The study designs were heterogeneous in the sense the intervention was at different time intervals, different types of steroids were used, different dosing, different protocols were used. There was significant crossover too, but generally there was one particular trend. That is, there was an improvement in lung physiology, in that the lung injury scores reduced, oxygenation improved. There was a reduction in the systemic and pulmonary vascular inflammatory markers. There was a tendency to remain on shorter duration of mechanical ventilation, etc. But unfortunately, the largest and most robust of these RCTs done by the ARDSnet investigators, published in 2006 by Steinberg, did not find any mortality benefit, although it also showed some of these beneficial effects on lung physiology. The other problem with these trials was that lung protective ventilation, now considered a standard of care for ARDS, was not universally implemented. The other significant finding was that mortality was higher when steroids were initiated after 14 days. As a result of such small, low quality evidence with such heterogeneous designs and varying protocols, the use of steroids remains unpopular, as reflected by the LungSafe study, which showed only 18% of the 2,377 patients that it assessed actually received steroids. The next logical step was a meta-analysis, and I've chosen this particular meta-analysis published by Meduri because it has this is an individual patient data meta-analysis of 4 RCTs studying methylprednisolone use in ARDS. Because the common complaint is that most of the studies are small and hence will not be powered to detect any treatment benefit. By using an individual patient data meta-analysis, it is possible to get an improved measure of treatment effectiveness. So basically, it included about 322 patients in the individual patient data meta-analysis, along with trial level data meta-analysis from 4 other RCTs investigating hydrocortisone. And the results were that steroid use did result in shorter time to extubation, increased number of ventilator-free days, decreased length of ICU stay and hospitalization, and mortality was also lower. They were also noted that there was no major side effects except for hyperglycemia, although maybe these studies were not powered to detect such a change or event. Most of these studies used intense surveillance, and as a result, there was no increase in the incidence of hospital-acquired infections, pneumonias in the treatment group. So in general, what we did observe was that most patients were extubated earlier, more patients were alive ventilator-free. So as a result, we had a first recommendation back in 2017 by joint recommendation of ESICM and SCCM, which recommended, based on its own analysis of data of all these RCTs, that steroids should be used. Again, even here you can clearly see that there is wide confidence intervals, a lot of crossing over, especially in the mortality assessment. There was much better effect when seen with regards to ventilator-free days at day 28. But basically, they recommended that steroids be used in moderate to severe ARDS, especially early on, before 7 days, but ideally less than 72 hours of onset of disease. And they have recommended a regimen with methylprednisolone. They have also suggested the use of infection surveillance, and they have recommended that the steroids be tapered or weaned slowly. This again, because of the nature of the quality of the evidence, they've only given a moderate quality recommendation, and it's entirely conditional. And as a result of this, steroid use continued to remain unpopular in the treatment of moderate to severe ARDS too. Before going to the treatment of, before going to the main trial that I wanted to highlight, which is the DEXA-ARDS trial, just wanted to review the evidence for steroids in severe community-acquired pneumonia. Again, here we have extremely conflicting results. In community-acquired severe pneumonia, there seems to be some benefit with regards to use of steroids. A Cochrane meta-analysis did find less likelihood of treatment failure, reduced ICU length of stay, some positive signs, but there was no clear benefit of mortality. As a result, you can see that the recommendation is not universal. SECM, ESICM recommended it, the IDSA did not recommend it. Now, coming to the next category, which is viral pneumonia, which is of particular interest since we are going to be discussing COVID pneumonia, which is a viral pneumonia. Results were even more conflicting. In SARS and MERS, there was a delay in viral clearance with the use of corticosteroids and a general tendency towards harm, especially in MERS. And the use of corticosteroids in influenza pneumonia was even more conflicting, with one meta-analysis showing increased mortality with use of corticosteroids in influenza pneumonia. So in this background, steroid use in ARDS continued to remain unpopular. And then came the COVID pandemic early this year, and also came the results of the DEXA-ARDS trial by Jesus Villar, published earlier this year. A multi-center RCT done in Spain. This trial is special and has multiple salient features. It's a much bigger trial than the rest of the trials, although there was one issue in that inclusion was stopped earlier because of sluggish recruitment. But the other salient feature is that they included only severe ARDS, PF ratio less than 200, and they included them only after optimizing the ventilation for a period of 24 hours. So they enriched their inclusion, and as a result, excluded patients who would otherwise be pseudo ARDS, so who improved on the initial 24 hours of ventilator optimization. Groups were remarkably well matched at baseline, and the most common cause of ARDS was pneumonia or sepsis. This is the dose of DEXA that they used, 20 mg IV OD from day 1 to day 5, and tapered to 10 mg IV OD from day 6 to day 10, and then it was stopped. There was no tapering, and if the patient was extubated before day 10, the drug was discontinued after dosing on that day. And the results were extremely positive. There was an increase in ventilator-free days at day 28 by almost 4 days, a decrease in all-cause mortality at day 60. There was a decrease in the actual duration of mechanical ventilation on survivors at day 60, and there were no major side effects except for hyperglycemia. So there were some weaknesses, as I already mentioned. The trial was terminated, inclusion was terminated early, it was unblinded. The other issue was the physicians excluded the patients who they felt will benefit from steroids. But again, this is a positive in the sense that means the patients who were included in the trial were not expected to benefit from steroids. So again, this is a strong result. And so when the results of the DEXA-ARDS were added on to the existing results from the meta-analysis, the positive results are further enriched. Patients, as a result, were extubated earlier. were discharged alive from the ICU and the hospital earlier than the patients in the control group. So to summarize this evidence, I would just like to just show the main clinical points that matter based on the evidence. So which patient should be give steroids, which steroid should be used, at what dose, what is the duration of steroid use ideally, and what side effects to expect. With regards to which patient, I think that steroid should be given to patients with whose etiology of ARDS is either severe pneumonia or septic shock. But again, it's whether it will be beneficial in conditions such as ARDS, which is elicited by trauma, is still not known. It should be given early. Ideally, it should be given less than 72 hours, but definitely before 7 days. It should not be given after 14 days. The benefit between 7 to 14 days is not very well proven. And definitely it should be given to the more severe forms, moderate and severe ARDS, and not the questionable benefit in the milder forms. Which steroid? Again, the DEXA ARDS trial was the first trial to evaluate dexamethasone's efficacy in treatment of ARDS. No other trial had before that evaluated that. I don't know why, because it has a high potency, pure glucocorticoid effect. There's no mineralocorticoid activity. That means less volume overload and less lung swelling, edema. And its half-life is longer. So that means it can be stopped abruptly and it will auto taper without causing symptoms because of rapid tapering. So basically it's less complex to use and the tapering is easier. So there's also an emerging evidence that mineralocorticoid use effect in ARDS has a harmful effect. Methylpred was the most extensively studied in all the meta-analysis. It has a good pulmonary availability, as often cited by many pulmonologists, but predominantly it has a glucocorticoid activity, but it has a shorter half-life. So if stopped too early, symptoms could rebound and reintubation has been noted. Hydrocort has also been evaluated, but it has a mineralocorticoid effect, which probably will not make it an ideal drug to be used. With regards to dose, this was a dose suggested by the ESICM, a rather tedious dosing of 28 days and a tedious tapering as well. And this was one of the reasons why methylpred use in steroids was not very popular. Well, DEXA at the dosing recommended by the DEXA ARDS trial happens to be much more easier, and it is equivalent to about 1 to 1.5 mg/kg per kg dose of methylprednisolone. And experimental studies have shown, with regards to a pulse dose, experimental studies have shown that a high dose may cause an initial benefit but later lead to harm. And this has also been proven by many other retrospective studies. So pulse dose is definitely not recommended, and it may cause more infectious complications as well. Adverse effects, most of the studies did not show any major adverse effects. Hyperglycemia was the most common one. Again, hospital-acquired infection is our major concern. But one thing that needs to be noted, that in almost all these trials, they had incorporated a strict surveillance practice. Steroids will blunt the fever response. I don't know whether that is actually practical in most Indian ICUs. But the other complications such as UGI bleed, pancreatitis was not exactly increased. And the other concern, neuromyopathy increase, was not also higher in the treatment group, even when neuromuscular blocking agents were used. So now what are the lessons based on this evidence for ARDS? So now that we've reviewed this evidence, now it's pretty clear that in COVID, steroids are beneficial. But I don't think this was the same when we initially began evaluating this particular drug. because of the negative evidence from MERS and SARS pandemics, steroid use was extensively discouraged. And many bodies and many scientists did not recommend steroids. In fact, WHO said steroids should not be used outside of trials. And only SCCM and surviving sepsis gave a rather weak recommendation for use of steroids. But now that we have the convenience of the recovery trial results and the meta-analysis from Dr. Sterne, it's easier to look at this. But I argue that steroids were always likely to be beneficial. And I'll just describe some of the features in COVID which makes it likely that steroids were going to be beneficial. First, the pathophysiology. Classically in COVID, cytokine storm has been described. And I believe this is not very dissimilar to the dysregulated inflammation seen in ARDS. The histopathological findings. Here again, there is the classical histopathological finding in ARDS is usually diffuse alveolar damage. And the diffuse alveolar damage is also observed in COVID histopathology as well, but usually in the later stages. In the earlier stages, there are features such as microangiopathy and endothelial injury, which could be even more sensitive to steroids. So, but in the later stages, it becomes more or less similar to ARDS. Also, the virus also seems to have a specific virulence factor where it tries to evade the host's immune response by inhibiting the ability of the host to mount a response to corticosteroids. So steroids always had a solid chance of being beneficial. So I conclude by saying that the evidence favoring steroid use in ARDS is strong. It is proven, and efficacy is proven in COVID too. And the use of corticosteroids cannot be ignored.
Thank you, Dr. Ajay Padmanaban. We will take questions at the end. Just an announcement for the participants. Professor Horby and Professor Sterne need to leave in the next 5 minutes. Please post your questions for them in the Q&A box, and they will continue to respond. Our final speaker is Professor Sheila Nainan Myatra. Dr. Myatra is an intensive care physician and anesthesiologist working at Tata Memorial Hospital, Mumbai. She is a professor of intensive care at the Homi Bhabha National Institute University. She is the president and founder member of the All India Difficult Airway Association and also the vice chancellor of the Indian College of Critical Care Medicine. She serves on the steering committee of the Surviving Sepsis Campaign guideline committee that is setting up guidelines for COVID. She's also serving on the steering committee of several international trials, including the COVID Steroid 2 trial. She is the national coordinator for the COVID Steroid 2 trial and will be presenting the trial now. Thank you, Professor, and welcome to the forum.
Thank you very much, Bharath. So I will be presenting an overview of the COVID Steroid 2 trial. And before I start, Professor Sterne has already talked about the meta-analysis. And we know clearly now that there is a benefit of giving systemic corticosteroids in patients with critically ill patients with COVID Steroid 2. However, there are still some unanswered questions as to which may be, there hasn't been a head-on comparison between the different types of steroids. Also, trials which uses higher doses of steroids had to be prematurely stopped after the recovery trial. So no head-on comparison between different doses and also the ideal duration. So many unanswered questions. And in the COVID Steroid 2 trial, what we tried to address was to find out whether there was any superiority of using a higher doses of dexamethasone in these patients. So following these, the recovery trial and the meta-analysis, various guidelines were updated, and this is the WHO, the NIH, IDSA, and they recommended corticosteroids for 7 to 10 days for severe COVID-19, and they also recommended against the use of corticosteroids for non-severe COVID-19. And before we started the COVID Steroid 2 trial, what we did is that we tried to have a questionnaire circulated to the 26 sites about what was their clinical practice post-recovery. So we had results from 26 sites, and all these sites used corticosteroids for COVID-19, and 90% of them used it for all COVID-19 patients. And the most commonly used one was dexamethasone. And the median dose, the duration was about 9.6 was the dose of the corticosteroid used. And when we looked at the clinical preference, so these were the questions that we asked in the questionnaire: hydrocortisone versus placebo, or dexamethasone versus placebo, or hydrocortisone versus dexamethasone, or 6 milligram versus 12 milligram of dexamethasone, or 6 milligram versus an even higher dose at 20 milligram. And if you can see, most of the clinicians preferred a dose of 6 milligram versus 12 milligram of dexamethasone. So I'll give you a brief overview of the COVID steroid 2 trial. So we compared 6 milligram with 12 milligram of dexamethasone in patients with severe COVID-19. And the aim of the study in testing 12 milligram, this was the intervention arm, was we tried to see whether there was any benefit, whether there was an increase in days alive without support, life support, increase in days alive and out of hospital, or mortality, and to check whether there was any harm, like serious adverse reactions, or any increase in the mortality. So the design of the study, this was an international parallel group stratified blinded randomized controlled trial, 1,000 adult patients with COVID-19, and they should have severe hypoxemia, and they were randomized to either dexamethasone 12 milligram up to 10 days or dexamethasone 6 milligram up to 10 days. Now, this is just a chart showing you the organization, and this trial originated in Denmark, and subsequently it was extended to other countries, Sweden, Switzerland, India as well. And here you can see the flow chart of the management committee. So you have the management committee from the hospital, Riggs Hospital in Denmark. And in India, we have the George Institute in New Delhi. We also have the Apollo Chennai Hospital and the Tata Memorial Hospital, and the principal investigators from there who are part of the steering committee. From Apollo Chennai, we have Dr. Bharath is there, from Tata Memorial Hospital, myself. And from the George Institute, Sydney, we have Dr. Bala Venkatesh, and we also have Sharon Mikalev and Naomi Hamid. And from India, the George Institute, New Delhi, we have Professor Jha, and various other sites from Sweden and Switzerland on the organization committee. Now, coming to the trial, the inclusion criteria is patients who are 18 years or above. So adult patients, they should have confirmed COVID-19 requiring hospitalization and should be on one of the following. So they had to be mechanically ventilated or have non-invasive ventilation or use of CPAP for hypoxia, essentially oxygen supplementation with a flow of more than 10 liters independent of the oxygen delivery device that was used. Exclusion criteria was use of systemic corticosteroids for any other indication other than COVID-19, use of systemic corticosteroids for COVID-19 for 5 consecutive days or more, invasive fungal infections. If they had active tuberculosis, fertile women under 60 were tested for pregnancy, or known hypersensitivity to dexamethasone, or previously randomized to the COVID steroid 2 trial, and of course, if informed consent was not obtainable. So these were the 2 arms, the intervention and the control. The intervention arm was 12 milligram of dexamethasone, and this was given as a bolus injection in 5 ml of isotonic saline once daily. And the control was 6 milligram of dexamethasone in isotonic saline, 5 ml bolus given once daily. Now, the steroids were continued up to 10 days. Now, if the patient had already received corticosteroids prior to randomization, this was permitted up to 5 days. And if the patient had received more than 5 days of consecutive days of corticosteroid, then he was excluded. And then depending upon the number of days of corticosteroid that was the patient had received, in the intervention period was calculated accordingly, so that there was a total of 10 days. What were the outcomes? Now, the primary outcome was days alive without life support at 28 days, invasive mechanical ventilation, circulatory support, and renal replacement therapy. And the secondary outcomes that we looked at was SARS at 28 days, any new episode of septic shock, invasive fungal infections, clinically important GI bleeding, and anaphylaxis. And these were the concerns that we had with the serious adverse reactions with the use of steroids. And of course, all-cause mortality at 28, 90, and 180 days We looked at days alive without life support at 90 days, days alive out of hospital at 90 days. And there was also health-related quality of life questionnaire that was conducted telephonically at 180 days using the EQ5D5L and the EQ-VAS scoring systems. And more details about the trial is available on the website. And I would like to update you on the trial status. So we're looking at about 1,000 patients, but we have already recruited about 132 patients so far. And so the progress is going quite well. In fact, in the last 2 weeks, it's really picked up and the numbers are increasing. And if you look at the trial recruitment and you look at the distribution of the different sites, as I mentioned, 132 patients have already been recruited, and from various sites across India, Denmark, Switzerland, and Sweden. And in India, we have more, already 7 sites that are active and more sites yet to join. And we have very close to 60 patients which have already been recruited in these sites. And this is the trial sponsor, who's Professor Anders Perner from Denmark, and his PhD student, Dr. Mari Munch, who is a coordinating investigator of this trial. Thank you very much for your attention. Happy to take questions.
Thank you, Professor Myatra. I would request Dr. Ajay Padmanaban to turn on his camera. I think Professor Horby and Professor Sterne have had to leave. Professor Horby did answer quite a few questions on the Q&A, and I think those answers can be seen by everyone. We are actually completely out of time, so I will just try and fit in a couple of questions. Maybe first for Dr. Ajay Padmanaban. Ajay, great presentation. Thank you so much. There's a lot of a lot of questions and messages in the chat box about the duration, and we know that patients continue to be hypoxic, beyond the 10 days. Do we have any data to support what to do beyond that, and what would your own recommendation be in patients who are continuing to be hypoxic?
Okay, if I would have to go back to the data from ARDS again. If you look at the data from ARDS, they used, for instance, when they used methylprednisolone, they used it for 28 days. And the benefit was similar to the what dexamethasone, which was used for 10 days. So Dexa was stopped abruptly. If you look at both the recovery trials results as well as the results from Dexa ARDS trial, as well as some of the trials where dexamethasone was evaluated in the context of COVID, like Codex trial and Dexa ARDS trial. So it doesn't, to me, I don't think that extended steroids beyond 10 days is beneficial. Looking at the pathophysiology of the disease, it seems that if you look at the histopathology of the disease, it's in the early stages which are more steroid responsive. And once it enters the late stages, it more or less resembles ARDS. And we have seen that continuing steroids late into ARDS is not really beneficial. So I would say that extended steroids may not really be beneficial, and it may have its own side effects.
Great. Thank you. Thank you so much. One question probably for Professor Sheila Myatra, and then we will wrap up. Professor Myatra, is there any enrichment criteria for entry into the trial? A specific inflammatory marker, or is it just oxygen requirement, and how have you defined this?
Right. So no, there are no such markers. We're not looking at IL-6 levels or any other levels for entry. We're just looking at critically ill patients with severe COVID. And the meta-analysis and recovery trial has already shown that there's no benefit in the patients who are not oxygen dependent, the stable patients. So this is a sicker patient that we're looking at. And the cutoff that we took is that the patient had to be on 10 liters of more of oxygen using whatever the delivery device was available, whether it was high flow or just oxygen mask or nasal cannula. So that was the criteria that was used for entry. And we didn't look at any inflammatory markers.
Great. Thank you. Thank you so much. We have completely run out of time. I do apologize for running a bit over our scheduled time. Thank you all for joining. We know that there are still unanswered questions, whether it is long-term functional outcomes, the risk of infections in settings where MDR bugs are a problem. There are questions around, on the effect on viral replication and so on. and hopefully further epidemiological work and trials will answer all of those questions. Thank you all for joining. Before I wrap up, I want to thank the teams at ISARIC and the George Institute and all the social media teams, but specifically Nina Jameson, Liliana Resende, Louis Cook, Elliot Ross, Harry Waugh, Tom Gothrop, and then Gail Carson, from the George Institute in India, Professor Vivekanand Jha, and from the Chennai chapter of Indian Society of Critical Care Medicine, Dr. Raymond Dominic Savio. Thank you all for joining. Have a great evening. Thank you.
Thank you very much.
Thank you. Thank you very much.
Thank you. Bye, everyone.
Bye.
Bye.